For the most part, this lesson is over chapter 3, so we're going to look very closely at chapter 3 of our book. We kind of got ready for chapter 3 a little bit. During week 3, we kind of did an introduction to the conduction system, and then week 13, we looked a little bit more at the ECG and conduction system. But now what I want to do is kind of go walk with you through the book. So we're going to start on page 30. And so on page 30, I want you to look at the picture, and I want you to familiarize yourself again with the SA node, where it's located, and you need to know that it is the pacemaker of the heart. And then the AV node, which is lower in the right atrium, and its purpose is to slow the conduction that comes from the SA node. The purpose of the AV node is to delay that conduction before it sends it on down to the ventricles. Then on page 31 starts basic ECG analysis. You need to know that the baseline is called the isoelectric line. That's just the baseline. And look on page 32, and that reviews the 12 leads. Remember, there's 10 electrodes actually applied to the skin, but those 10 electrodes equal 12 leads or 12 views of the heart. Now the picture on page 32 shows you lead 1, lead 2, and lead 3, and then it shows you the V leads, V1, V2, V3, 4, 5, and 6. It does not demonstrate the AVR, the AVL, and the AVF. So we need to look at that. So this picture from week 13 is a good demonstration, and so you need to memorize these. This is very important. You need to know where lead 1 is located. It's located here. Lead 2 is here. Lead 3 is here. Then AVR, AVL, and AV foot. Then you have your V leads, 1, 2, 3, 4, 5, 6, and these look at the heart from anterior to posterior, whereas these all look at the different angles from right to left or left to right. So these are very important to have memorized. And then you also then you have to memorize what leads coincide with what part of the heart, and then what leads coincide with what coronary artery. And so, of course, what I'm referring to is this. In the inferior leads, you need to know what leads refer to inferior and what artery, which leads refer to left lateral and which artery, and so on and so forth. Okay, back to this paper. Then page 33 of your book at the bottom, it goes over each of the waves, segments, and intervals. And so you need to understand what each of these waves and segments, what it's referring to. Pay especially close attention to the ST segment here, and know that in a normal patient it is located on the isoelectric line. Okay, so it should just run along that center line on the paper. Every wave, segment, and interval is discussed in detail starting on page 34. So again, it goes one by one. It talks about the P wave in depth, and here's again, pay attention to the ST. Here's the problem here, is that the normal waves, segments, and intervals all look different on which lead you're looking at. Okay, and that's the frustrating part about EKGs, is we learn it this way, but really, in honesty, this is only normal in just a couple of those leads. All of the other leads look different, meaning the P wave in some of the leads is not just a positive deflection. It could be a biphasic, meaning up and down deflection. Some leads don't have a Q wave at all. If the lead does have a Q wave, it should be very, very small. A deep Q wave means an infarct, and we're going to talk about that here in a minute. Again, the R wave, in all of the leads, the R wave isn't positive. Sometimes it's biphasic, sometimes it's up and down. Again, the T wave in all of the leads is not a positive deflection. So the one we're looking at here, the one that's most common to us, the one that we learn from, it would be maybe lead 1, maybe lead 2, but then all of the other leads, this varies, a little bit. So that's the hard part about learning ECGs, is that each 12 of those leads, the normal wave tracing looks different. Okay, turn now to page 37, and this is where it begins talking about arrhythmias. An arrhythmia is an abnormal rhythm. An arrhythmia is any rhythm other than normal. An EKG can demonstrate many pathologies, and here I have them listed. It can, of course, demonstrate conduction abnormalities. It can demonstrate an enlargement of one of the chambers of the heart. It can demonstrate electrolyte imbalances, and of course it can demonstrate ischemic heart disease, which would be the precursor to the myocardial infarction, the heart attack. So the EKG can demonstrate many of these different pathologies. The atrial arrhythmias could be atrial fibrillation. The nodal or junctional, the AV area or junctional area, that's where your first and second and third degree blocks occur. And what that means is just simply the signal doesn't get through. It's blocked. It literally gets blocked and doesn't get to go on through to the ventricles. Ventricle arrhythmias, of course, could be ventricle fibrillation or VTAC, tachycardia, and then again conduction blocks. And again, that's kind of referring back to these junctional blocks. And it talks about heart blocks beginning on page 40. But go ahead now and turn to page 42, and it talks about the ST segment. So again, that's an important segment in cath lab world. That is the period between depolarization and repolarization. So therefore there's no electrical activity occurring at that time, so therefore it's an isoelectric line. So it should be just a flat line along that center line. When there is a problem, when blood flow is impaired, the ability for the heart to repolarize or relax is affected, and so this affects the ST segment. So that's why during myocardial ischemia, which ischemia is decreased blood supply to the myocardium, to the heart muscle, or infarction, which is tissue death due to ischemia. Okay, early on in the evolution of a heart attack or myocardial infarction, the first things that are seen on the EKG are the T wave can flatten or actually invert, meaning upside down, and the ST segment will also flatten or invert. So these are that's the symptoms, or what it looks like early on. And then later these progress into an ST segment elevation. And that's when you know that it's serious. That's when you know a lot of damage is occurring. Up here, damage is occurring, but it's not quite life-threatening just yet. But then these can progress into a ST segment elevation. And that brings me to the two types of heart attacks. Okay, there are two types of heart attacks, non-STEMI and STEMI. STEMI stands for ST elevated myocardial infarction. So there's two types of heart attacks. So when a patient comes to the emergency room with chest pain, they look at the EKG and their ST segment is either elevated or it's not. If it's not elevated, they still could be having a heart attack. It's just not an ST elevated heart attack. Now, what's the difference? Okay, well, basically there's not. They're actually the same thing. They're caused by the same thing. It's the exact same process. The difference is that an ST elevated heart attack or myocardial infarction is transmural, meaning it spans the entire thickness of the heart wall. And so therefore it's more emergent. Whereas a non-ST, so here it's demonstrating the ST segment is actually depressed and not quite elevated yet. So, and it's demonstrating that only part of the thickness of the wall is being affected, meaning that ischemia is only occurring in this colored portion. It's not all the way through like it is here. So, I mean, that's the only difference. So they're both basically the same thing, but how it affects us is we do get called in the middle of the night if it's ST elevated because it's more muscle tissue being affected, and sometimes we don't get called in the middle of the night for these non-STEMI heart attacks because those can sometimes be treated with medicine, or sometimes they just wait to see if it's going to evolve to an elevation, and and then we intervene. So again, letter A, this one is a non-ST elevated myocardial infarction, so they're still having a heart attack. It's just not quite as severe, meaning it's not quite affecting as much tissue as this one here. And again, this is demonstrating the difference in the EKG. Here the ST segment is depressed, here the ST segment is elevated. So both of these are heart attacks. They're both caused by the same thing, both caused by an obstruction of a coronary artery. Just this one is not affecting as much tissue as of yet, but it could very well evolve into that. Okay, and then this picture is just basically demonstrating the same thing. Here is showing you ischemia, which is decreased blood supply, an injury, meaning tissue is starting to die, and then infarction is actual tissue death. And again, demonstrating this is what the EKG would look like for a normal heart muscle. Ischemia is showing you that looks like that T-wave is starting to invert. Here now injury, so now we're getting an actual injury. The heart muscle is starting to die, so it's ST elevated. And then an infarct where there is actual tissue death, then that's when a Q wave or a pathological Q wave, you might hear it called, can occur. So again, remember your normal Q wave is very shallow. It doesn't go very deep at all. So if you have a Q wave that goes this deep, then that means there is tissue death in that heart. And so again, those are called pathological Q waves, just meaning there is tissue death. Now, sometimes that Q wave will recover sometimes they stay for the rest of the patient's life. Okay, then finishing up with chapter 3 here. Starting on page 44, localizing the infarct, talks about, again, which lead looks at which area of the heart. And there's a table there on page 45, table 3-2. It doesn't name the artery associated with it, but you have that in week 13, or week 12 rather, week 12 handouts. Page 44 also, again, talks about that Q wave infarct. Look at the EKG on page 45. Q waves in a normal heart should be very small, but this is showing deep Q waves, so again, representing infarct. Page 46, under emergency treatment for arrhythmias, talks about ventricular fibrillation and pulseless VTAC require defibrillation. Complete heart block, which is called third-degree heart block, requires either transthoracic, which is external, or transvenous pacing. Symptomatic bradycardia treated with atropine. Electrolyte abnormalities. Hyperkalemia and hypomagnesemia can cause a widening of the QRS complex. And then starting on page 47 all the way to the end of chapter 3 is a detailed review of what to look on at an EKG. Especially pay special attention again to your waves and segments, like your P wave, just knowing that P wave represents atrial depolarization, and again that ST segment. And again, this section is pretty detailed. You don't need to know it in that great of detail, but if you just have a general idea of what each line and segment does and what it represents, that's what you need to know.